The next presenter is Dr. Helmy. He will be talking about approach to severe stable coronary artery disease and cardiogenic shock. Should revascularization be offered at all? Dr. Helmy is a professor of medicine and division of cardiology, chief of cardiology at LSU Health.
Good morning, everyone, and thank you for organizers for the kind invitation, and congratulations on an excellent conference so far. I've been quite impressed with the format, cutting-edge presentations, interesting debates, and more importantly, controversial topics, which my topic falls within that scope. No disclosures in relation to this topic. So, my task was to talk about patients with severe stable coronary disease who present with cardiogenic shock. But wait, they cannot have acute coronary syndrome. That would be way too easy. So we're going to have to tackle this in a sort of an innovative way, and we'll sort of work through this. So there's really no data on this subgroup of patients who are walking around with severe coronary artery disease, presumably depressed EF, and then come into the hospital with cardiogenic shock, not due to acute coronary syndrome or a STEMI. So the way we're going to tackle this, I hope, is we're going to tackle the components of this scenario. We're going to tackle revascularization in stable coronary artery disease. We're going to tackle revascularization in ischemic cardiomyopathy. And we're going to tackle cardiogenic shock in the subgroup of patients. And at the end, we'll put all this in the mix, and we'll see what comes out. So let's talk about revascularization in patients with ischemic cardiomyopathy. Stable coronary artery disease with preserved EF is guided by ischemia and angina, and the ischemia trial showed that there was no survival benefit for revascularization. It's a little bit more complicated for ischemic cardiomyopathy. What do you do with a patient with 80% LAD, 80% RCA, and an EF of 30%? Do you watch them? Do you revascularize them? And this is an area of controversy, but there is some data that we're going to go through. Surgical revascularization is one option, and PCI is another option. Let's talk about surgical revascularization. The STITCH trial in 2011 was published and looked at patients with depressed EF and severe multivessel coronary artery disease who underwent CABG. And if you look at the overall survival, there was no difference between medical therapy, no revascularization, and CABG. But if you dig deeper, you will see that there was improvement in cardiovascular death and improvement in the combination of death and rehospitalization. So this was a signal that CABG was useful in these patients, and the surgeons were very excited. We're not getting into the controversy of the viability testing there, but it is something that to keep in mind, that CABG is helpful. It took us 11 years to show a difference in overall mortality for this subgroup of patients. So if you look at the left side of the slide, at 6 years, the p-value was 0.12, no significant difference. At 11 years, now we have overall mortality benefit in favor of CABG that is statistically significant. So it takes a little bit of time for these effects to come in. So now we have established pretty much that if you have somebody with severe multivessel disease and depressed LV function, then CABG is a very reasonable option. What about PCI? The REVIVE trial was recently published, and it's 2022. And it looked at patients with depressed EF, severe multivessel coronary disease, and evidence of viability. And they thought, okay, we'll do PCI for these patients versus medical therapy. And that was an interesting concept because we've established CABG, now can we translate or extrapolate to percutaneous intervention? Unfortunately, at an 8-year follow-up, there was no difference in the primary outcome of death or hospitalization between medical therapy alone and revascularization using PCI. So this was a punch in the gut for all interventional cardiologists who anecdotally, we have seen these patients come in with an EF of 20%, multivessel disease. You do high-risk PCI, protected PCI, whatever you want to call it, and 6 weeks, 3 months later, you look at the EF and they're 40% EF and they do not need an ICD and they're doing very well. But this is the randomized data and this is what we have to work with. This was irrespective of the degree of dysfunctional viable myocardium. So if you look at the difference between the STITCH trial and the REVIVE trial, one showed survival benefit at 11 years. The REVIVE trial, we're only at 8 years. So if we wait a little longer, can we delineate a difference? A lot has changed between the two trials. We have ARNIs, we have SGLT2, which both affect the overall mortality in these patients. So can that be a factor? The other interesting and sobering factor that came out of this, the fact, was that there was no significant improvement in LV function. We've all talked about recovery of LV and improvement in the function, but in this study, after revascularization, there was no improvement in ejection fraction. So the REVIVE trial basically is challenging the concept of hibernating myocardium. We've all known that if you revascularize hibernating myocardium, you improve function and you recover ejection fraction. Another interesting thing, and I could not find this in the stitch, but in the REVIVE trial, the observation mirrored those in the stitch where revascularization by CABG did not affect the LV function as well. So no matter what you do, apparently, you cannot improve LV function. And this is, again, contrary to what anecdotally we all know, whether you're a surgeon and you walk in and you put grafts and then the heart is pink and it's pumping, or in the PCI where things improve dramatically. So the questions for the REVIVE trial: complete revascularization, residual syntax score, reduction in ischemic burden, all areas that we need to explore further. The RESTORE EF was a different trial that looked at PCI with depressed EF with elective, and they looked at improvement in ejection fraction. And in this study, there was significant improvement in ejection fraction in the patients who got revascularized as compared to their baseline EF. And the worse the EF you start with, the better improvement you gain. And if you achieve complete revascularization with a residual syntax score of 0, your EF is better than the patients who were left with residual ischemia. And this was mirrored again with reduction in heart failure symptoms and in anginal symptoms. So what do we do with these patients who are walking around with ischemic cardiomyopathy and come in with cardiogenic shock? Many etiologies, not ACS, but once you start that, you have added stress on an already ischemic and compromised myocardium. You have demand ischemia because of decreased perfusion pressure, hypoxia, tachycardia, acidosis, and of course, when we support them, we use inotropic agents, which increase demand ischemia. And you start the spiral of cardiogenic shock. The SKY classification has been mentioned, but I will bring to your attention that this classification does not apply to chronic cardiovascular disease, which is basically what this talk is about. Talking about acute coronary syndrome would have been too easy. So management for shock patients, it's not been this patient population has not been studied. I think mechanical support, I would suggest, would be implemented early to avoid inotropic agents and to offload the ventricle and improve perfusion. And you can use your best judgment after that. You want to support and stabilize and then leave the patient with baseline ischemia. I don't know how many of us would do that. Support and stabilize and revascularize in acute setting, or stabilize and consider later revascularization. Those are all options. If you do consider revascularization, then you probably need to have a clear plan, experienced centers, and use of hemodynamic support for PCI. Surgeons are not usually very excited about taking multi-vessel disease patients with EF of 10% and cardiogenic shock patients to the OR. So, how do you do support? Impella versus balloon pump. The Impella use allowed us to show decrease in MACE. Now, keep in mind that these are not cardiogenic shock patients. These are high-risk elective PCIs. An important factor here is that the Impella benefit was seen post-discharge up to 90 days and not in the acute hospital setting. So it's not used to basically get you through the procedure. It's designed to allow you the opportunity to improve your revascularization and optimize your revascularization so you can achieve long-term better outcomes. And we know from Bill O'Neill's data that the more vessels you treat, the more revascularization you achieve, the less MACE you have. So I will take one last slide, if I can. One last slide. So in conclusion, there is no data. There is no data to tackle this scenario of somebody with multi-vessel coronary disease and depressed EF who comes to the hospital in cardiogenic shock not due to acute coronary syndrome. There may be some data for CABG and ischemic cardiomyopathy stable patients. PCI remains controversial. The randomized data does not support PCI. The observational data does support a protected PCI. And again, this boils down to the art of medicine and how the patient is doing and how you can manage that patient. Thank you very much for your attention.
Thank you very much, Tarek.